Good morning, everyone. Welcome to the Culture of Safety Center Summit. My name is Mary Lynn Baldoff. I'm the CEO of QSource. QSource and Tennessee Health Facilities Commission, previously known as the TDH, kicked off this annual summit 2 years ago, but had to unfortunately do the first year virtually. So we are all very glad to see you all here outside your rectangle in person to have the chance to network among an amazing group of attendees. You are surrounded by people who are dedicated to long-term care, working together in a world full of daily challenges to ensure that our focus is on the most important parts, our residents and the staff. On behalf of QSource, we are thrilled to spend the day with you sharing knowledge, learning new information, and planning how we can help each other in our long-term care community. I'm going to pass it over to Jennifer Goodpaster, who is our long-term care director at QSource.
Thank you. Good morning, everybody. I'm so happy to see so many faces in this room today, and thank you for weathering the storms out there and joining us today. I'm just going to go over a few housekeeping issues with you today, and just some key points to get you through the day. If you have not already completed the pretest, there is a QR code that will take you to the meeting packet where you can download all the slides and also take the pretest. We have also provided CEUs for administrators, 5 CEUs for administrators, and 5.5 for nurses. I'm going to go to this next slide right here, and so this gives you the overview of that. Also, as an FYI, we're going to be recording the sessions today. We will take a break for lunch at 11:15. There is a restaurant on site. If it's not raining, there's lots of places to walk to, so you'll get a full hour for that. Following the event, you're going to get a feedback survey and post-test. We just ask that you complete these upon receipt, and then we will provide you with your certificate for your CEUs. For the administrators present today, we will notify NAB on your behalf, so you don't have to do anything with that. We also encourage you to ask questions to our speakers today. They have set aside time at the end of each session for you to do so feel free to speak up. Lindsay Bugg, many of you know Lindsay, she's one of our QI advisors. She's going to have a microphone, so you just raise your hand and she'll run over and bring you the mic so you can ask your questions. So I'd like to go ahead and get started this morning. I would like to introduce our first keynote speaker of the day, Dr. Arif Nazir. He is a board-certified geriatrician and a certified medical director with the American Board of Post-Acute and Long-Term Care Medicine. He currently serves as the Chief Medical Officer at Primary Care at BrightSpring Health, and he also assists with other CMO activities for American Senior Communities in Indiana and Signature Healthcare. In addition to his current positions, Dr. Nazir continues to be a published author, recognized by CMS as a top influencer for geriatric practice, an associate editor at the Journal of Society of Post-Acute and Long-Term Care Medicine. Dr. Nazir's honors include the 2022 McKnight's Gold Award for Innovation in Skilled Nursing Facilities for founded company CareAscend. Y'all please help me welcome Dr. Nazir.
Good morning, everybody. Thank you for the opportunity here. It's just always an energizing source of boldness for me to be in front of an interprofessional team like yours today. So it just means a lot to be able to speak. It just gets boring to talk to physicians all the time, honestly. You can't get much ideas from them. They're distracted and busy all the time. So I hope there are no physicians here because we'll have a lot of fun. Are there any physicians here? Yes. All right. So, as I was introduced, appreciate that. I mean, pretty much my efforts over the last many, many years have always been, since the very first day when I entered a nursing home as a medical director, which was 2004, I clearly remember that day. My arm was twisted by an administrator who came to me. I was providing care in a rural clinic in Sterling, Michigan, had no intention of being a nursing home physician. Like, man, who wants that boring job? I'm gonna be, a primary care physician. An administrator came to me as a new patient because he could not find a doctor who could give him the help. honestly, that's why he became my patient. He was like a 32 years old young gentleman, pleaded to me like, Dr. Nazir, thank you for taking care of my high blood pressure, which I don't even have. This is why I'm here. I really want to talk to you. Would you want to be the medical director for my nursing home? Honestly, I'm kidding you not. This was the first time I was given the idea of being a medical director. I'm like, man, like, what are you talking about? He's like, oh, I got this place called a nursing home. You could come here. You could be a medical director. We'll make sure that everything is done for you. All you have to come is show up for once a month. We'll take care of everything for you. Like, what? I will pay you like $2,000. Like, what? You'll pay me $2,000 for what? For just coming once a month? You just sit down in the meeting. You know, we'll do everything. Like, honestly, unfortunately, I wish I could say that all of that has changed. It has not, unfortunately. But that was my first exposure, and that got me interested into geriatrics. I went back and did a fellowship, and that just sticks with my mind. And I still remember the first QA meeting I went to, that Itsy Nursing Home in Sterling, Michigan. I promise you, I entered that room for a QA meeting, and people just looked at me like, I had two heads, like a physician in the QA meeting. And I sat down there, and I still remember 80% of the conversation I had to bear through was about laundry. I'm like, guys, so I really had to I suffered through that laundry conversation because I had nothing to add about lost underwears. And it's not a joke. It is not a joke. It is a funny story. I went back. I said, okay, maybe, you know what, this was the laundry month. The next month will be about medications. That's okay. I didn't say anything. The next month, now was all about laundry again. And so I really had to talk to my DO, and I said, hey, Nicole, I think Nicole was the name. I said, can I talk to you? She's like, yeah. I said, like, do you really want me here? Or if you want me here, you have to engage me a little bit more. She's like, what do you mean? Like, can we talk about medications or something which I know about? Like, she's like, oh, really? Like, so this is what the situation was, and that day I kind of got it, like, man, this is silly. We are in USA in the 21st century. It was like 2004, and this is what we have to deal with in a healthcare system. And since that day, I got very inspired, like, what can I do to bring in physician partnerships so we can actually be a better team? And I promise you that 80% of it has not changed still, right? So it's like, it's the same message I'm giving over and over again. I do have some more white hair or gray hair, I would say, and I do have some little bit more experience. I work with 4 organizations in the role of chief medical officer, just because I really want to change the system. I want to assure you all that physicians, most of them don't bite, honestly. Some of them do, and if they do, well, you don't want to work with them, right? But physicians are ready to engage with you at a different level. You need to kind of check and see what kind of structures you are putting in place to empower them to be a good partner to you. So I hope today I can give you some tips so that you can go back right away and make some quick changes so that you can start getting more value. How many of you are here at DONs or at the DNSs? Yeah, so wouldn't you just love to have a little bit more partnership with your physician leaders? How many of you are administrators? Awesome. So I think you both, and again, of course, I respect every other discipline else is represented, but you both, these two disciplines, like administrator and DON, is so critical in what I'm going to be talking about around this. So as you guys, or you may not know, that physicians were thrusted upon you, or in this setting, in the 1970s because there was a disastrous outbreak of salmonella in Maryland, which led to 34 deaths, and suddenly people recognized that there was no physician to be found in that ordeal, and this got a lot of press, and that's where, the regulators and everybody else started talking about, like, where are the doctors in this? Because our patients and our residents are really, really sick. So that was the first time this topic was started, and then regulations were passed in 1974, 1980s, there was a back and forth, and then American Medical Director Association, American Medical Association, American Geriatric Society, and then AMDA, which is the Society of Post-Acute Long-Term Care Medicine, all then kind of pushed hard, and then the medical director mandate was restored and passed in the federal regulations. Let's do show of hands if this question is relevant to you. My medical director is highly engaged in enhancing quality of care in my facility. You're right. Who says you're right? All right, couple. Who says, well, somewhat? And who says absolutely? A little bit more. Awesome. The most important reason that I'm quite happy with my medical director is because she or he is a nice person. Oh, so none of you have a nice person as a medical director. Oh, I got it. Takes proactive interest in quality initiatives. Proactive, not that you're telling them, actually proactive interest in quality initiatives and outcomes, for example, hospital prevention. Maybe a couple? Okay. Provides me whatever I ask. For example, hey doctor, can you give me a UA on this patient? Hey, can you give me some pain prescriptions for this patient and a couple for me too? Well, that happens, okay? I work with like 200 medical directors. Unfortunately, there are stories like that where the DONs and administrators love their medical directors for the wrong reasons. So you don't want to get into that cycle. Well, there's nothing wrong in your medical director having all those three attributes. It's good to have a medical director who's nice, right? It's good that they can listen to you and work with you on evidence-based things. That's fine. But the best thing is that if they could be proactive, coming up with ideas, right? All right. If I am hiring a new medical director for my facility, the most important attribute I seek is, all right, so let's see, raise your hands with the one which fits with you. Has hospital, and you can raise your hand with everyone if you want, has hospital connections. This is it's a big one. I mean, I would say, yeah, I mean, it's strategically important. It shouldn't be the only reason, right? Humility. To me, I would highly recommend that one. That's an important one, right? Available 24/7, probably. They should have some structure that you can get access to them, right? Expert with regulatory frameworks, not a bad one to have, right? And then is a super clinician, right? So I think all these attributes are important ones, but to me, humility is something you cannot teach people. So I mean, so as the chief medical officer of multiple organization, I get engaged in recruiting physicians all the time. This is the number one attribute I'm looking for. I want to have first call with them, and the first thing, if that comes out their mouth is money, I'm done. If the first thing that comes out their mouth is like, hey, how can I help? Man, I'm bought in, right? So there's definitely ways for you guys to be very strategic. Do not ever get yourself in a bind because of physician status with the hospital system. Because if they bring some arrogance, which many of them don't in this day and age, but if they do, man, nothing is a better recipe than that, than disrupting your facility, than bringing in somebody with such attitude. So please make sure that you make these strategic decisions very carefully. And humility probably is the number one thing I would recommend. I do like to, because I talk about these myths and facts all the time, and I'm sure with all you experts here, most of the physicians, I think, believe in a lot of these myths on the left side. Probably you guys do not, but I always like to share this slide, that let's just talk about all the facts on the right side. All SNFs are required to have medical directors, right, by regulations. ALFs do not. All physicians must attend a COAPI meeting at least quarterly. I would highly recommend it should be monthly. Physicians can only be paid a fair market value rate. If you're not engaging in that conversation, if you're just coming up with these numbers because the physician asked you to give us monthly stipend, you're putting a big target on your back. OIG is getting very, very serious on these issues, so please do not play with fire. There's millions of dollars worth fines which OIG is doling out based on that. So please make sure every conversation should happen in a fair market value framework. It's better to have a third-party company to work with to get that fair market value assessment. Reach out to me. And I do apologize, I cannot stay long after this talk, which I love staying long because I have other meetings to get to, but I am you will be shocked how accessible I am. Like, you'll be shocked. So please use my name from LinkedIn. Just reach out to me. I promise you, you will get a response back from me within a day, if not sooner. I love connecting with the front line. To me, that is the most meaningful thing I do in a given day, other than just answering all those boring emails on my office. Connecting with the frontline team is the most important thing I do. So please take that opportunity. If you have any questions, reach out to me through LinkedIn. All right, to prevent Stark violation for medical directors, a contract and a description of administrative services is required. How many of you have seen a medical director contract, like really seen and read it? Please, good job, awesome job. And that medical director contract can be used for multiple reasons. Number one, to save your butt, because it's a Stark violation not to have one, or make sure it has the right things on it. It should clearly say that your medical director is going to be doing administrative work for you, not clinical work. The biggest problem I find when I talk to facilities and medical directors is that they are actually charging you whatever dollars while double dipping. They're seeing their 14 or 20 patients or 50 patients a day, and then you're also sending you a bill for medical directorship. That should not be done. You need to show clear evidence to OIG that your medical director is investing time which they're not using to bill for patient services. This is the biggest problem which I see, the riskiest thing out there. So please don't get yourself in a bind. Use that contract to have a conversation with your medical directors, like, hey, Mr. Medical Director, I really would want to set up a system so you and I can spend some time about talking about quality, and I'll give you some tips. How can you spend that administrative time? Please know many medical directors are not well versed in regulatory aspects and QI experts. They're not. They're just not there. So it's an important job for you have. All you to do is, I call it a subtle mentorship. You never want to do like overt mentorship, but you want to do subtle and occult mentorship. Every time you have a conversation with them, hand them some regulatory paper, hand them some new update. So it's a very important thing for you to do is make sure that you become a guide to them about the regulatory aspects, because a lot of them probably do not know those. And then hiring medical directors for their referral ability only is a critical violation. Okay, so it should always be an underpinning that with good medical directors on your team, you will actually create a beautiful quality brand, and that will bring more patients. Nothing wrong in that path, but just do not write in an email, hey, can you please find me a medical director who can bring more patients? I've seen those emails. I see them all the time. Please never, ever kind of go that route. So these are just important facts. Want to get them out of the way. So we published this paper. Why are we having this talk? Because role of physician and medical director in an interdisciplinary team for good quality outcomes is a must. I always say that quality and medicine is not delivered through voodoo, okay? It's not delivered through goodwill, right? I mean, how do we give people good care? By order and prescribing, right? Do you know what is the average number of medication our patients take in long-term care nursing homes? So I lead this national initiative through AMDA called Drive for Prescribe. If you do not know about it, I'll tell you about it. And we actually found out that in our country, 13 is the number. People are average taking 13 medicines a day. So medicine is happening through polypharmacy in our country, right? And prescribers are a must for quality of outcome, right? So you cannot get anywhere without engaging in a very good interprofessional structure. We published a paper about that a few years back. I always use a very simple example of why and how we should you involve in medical director relationship. So I will use this example. It's really pretty simple. Let's say let's use this example that you have a leaky faucet in your powder room, in your bathroom at your home. What are you going to do, right? You need to get it fixed. And if you're like me, you're clueless how to fix a leaky faucet, right? So what are the detailed steps for best possible outcome from there? You will need to know exactly which faucet is dripping, for how long it's been dripping. You will have to find the best plumber, right? If it's not your spouse, you have to find one. You have to think about the previous experiences. You may use some app to find one. Maybe you ask your neighbor, right? And then once you find that plumber, what you're going to do? You're going to sit down and talk to them. I'm going to say, hey, plumber, this is my faucet. It's been giving this problem. Can you fix it by tonight? I have guests coming tomorrow. I don't want to have a leaky faucet by tomorrow. Can you do that? So you set objectives and you set expectations for that. And then you say, hey, how much are you going to charge me? Oh, I'm going to charge you $11,000. Like, no, thank you, we're done. Let's openly talk about that. And then you decide the price, and then you come back after a few hours, you check the faucet, it is done. Thank you, Mr. Plumber, here's your payment. I want to use you forever. Let's work together. You really work for me, right? So this is how life works, right? When it comes to medical directorships, it shouldn't be any different. You need to know exactly what are the key issues in your building, strategic or clinical quality, right? Maybe strategic should be you have a value-based hospital system close to you and you want to improve in value-based systems. Well, you need a medical director who understands that, right? Maybe a hospital system is really a tertiary care center for cardiology services, right? How cool would that be for your facility to have somebody with good cardiology expertise? So you need to have a strategic or a clinical quality approach to thinking what kind of a medical director you probably need, right? So that's the number. Then you need to talk to your peers around you, like, hey, I'm thinking about Dr. Smith. He's shown some interest. Can you give me some intel? Like, how does he operate? How does she operate? Get some intel. Number 3, meet with them and openly talk to them. Why you think they would be a good fit, have a conversation. And then talk about money, like what are they going to charge? What value they're going to give you? Hey, Dr. Smith, we have corporate compliance office, we're going to do a fair market value. Are you okay with that? We're thinking about 12 hours a month would be good administrative time. Are you okay with that? When will you be coming for those 12 hours? Like, really openly talk about those things. You actually deserve they owe it to you to be able to speak about those things. And then you say, hey, Dr. Smith, for the first quarter, can we work on hospital prevention and heart failure? Those are my biggest 2 problems. Can you help me with that? So do not just let it open like, hey, Dr. Smith, you're my medical director, you're welcome, do whatever you want to do, I'll pay you $300 a month. It's not going to go well, right? So I think in my work with medical directors and with hundreds of buildings over the last many years, this is the biggest problem I find. I used to badmouth physicians a lot, I promise you, in these meetings like that, and then I kind of changed because I realized, okay, man, wait a second, I cannot blame my physician peers a whole lot because, they're not even getting any guidance, like what they should be doing in these roles. So I think we have to set up a structure for success for them to be successful. So medical directors, if you look at the code of federal regulations specify 2 duties for your medical directors. Number 1, implementation of resident care policies. And if you look at the detail, medical director is not required to write those policies. Thanks God. You do not want a doctor to write your policies. It'll be funny. You'll be just laughing all over the place. So they are just supposed to help you implement them, which is great. And then number 2, they are your go-to person for care coordination of medical care in the facility. The funniest thing I find about the second point is when medical directors come to me and say, hey, Dr. Nazir, Arif. I was like, yeah, I need to be paid more. I'm like, well, why? You're getting paid for 12 hours. You barely show for 10. Like, what am I missing? Well, Dr. Smith, he never takes his call, and building never finds him, and whenever they have a problem, they call me. I'm like, wait a second. As a medical director, weren't you supposed to fix that? So remember that your medical directors actually are responsible for making sure that your other doctors are in line, other practitioners are in line, that you have 24/7 call available. That's your medical director's job. So never let them come back to you and use that as a leverage for you to paying them whatever, right? So just remember that this is when you have a conversation with your medical directors, these are the things they should be doing for you, right? But those are 2 very overarching statements. So what AMDA has done, the Society of Post-Acute Long-Term Care Medicine, has actually helped translate that a little bit for you. So let's look at that translation. They actually turned it into roles, functions, and tasks, right? And these are the roles. Number 1, AMDA says, and CMS accepts, that medical directors should be doing these 4 important roles for you. Physician leadership. So they are actually the premium physician leader. So if you have other NPs, physicians, podiatrists, consultants coming in, they are helping you make sure that those other physicians and providers are providing high quality services. So that's the job of the medical director. They actually should be reviewing their notes. They should be looking at some of their work. Patient care clinical leadership, making sure that they have clinical administrative skills to guide facility in providing care, like, hey, let's set up a heart failure program, right? Let's set up a COPD program. That's their job to help you. Quality of care, they should be sitting down with you, not just at a boring data dump copy meeting, but every day there should be a learning approach of talking about quality. Hey, tell me about our last week's hospital admissions, how many admissions we had, let's talk about them. Hey, how many pills are we taking on average in this building? Like, it should be a day-to-day conversation. You guys should be like geeking it out together, right? I mean, like Dr. Smith, like look at our numbers are down. Please get into that cycle, right? It's so much more fun when you make conversation around data and metrics, and it should happen every day. And then education, information, communication, not that physicians know everything, but physicians know a few things, right? Pull them in for that conversation. A lot of physicians you have great relationship with hospital systems, they work with other organizations. Ask them to present some of those things that are happening around you so that you can be educated, you can learn, you can be in cutting edge. So assign them some of those roles. So those are the 4 important roles AMDA says. And then AMDA then goes into a further split. How do you describe those roles into 9 functions? And administrative, professional services, COAPI, education, employee health, connection with the community, rights of individuals, social, regulatory, political, and economic factors, person-directed care. So these are the 9 functions. And so, in some other talk, I would have gone into description of all these, but I'm not going to bore you with that. I'm going to actually give you some other cool examples. And you will get these slides, by the way. So, all right, so partnering with the medical director. So the understanding facility key needs and challenges, please seek an A player. I call them A players. You can call them whatever you want. You can call them supermen or superwomen. But look for these attributes: humility, teamwork, clinical expertise, regulatory understanding, QI, and solution-oriented. You don't want a medical director who just comes in like, oh, that's broken, you don't have staff, I don't like you, come on, give me more, I need a nurse to round with me, like, come on, they're just gonna drag you down, right? I mean, you want a physician partner who actually is sitting down with you, understand the challenges, and then works with you creatively. Have an interview process with key leaders and facility staff. Make them interview your CNA. Like, hey, CNAs, not interview, but help. If you have a prospect medical director, make sure they come in and they meet your CNAs and talk to your CNAs. Like, what do you think about it, her or him, right? There should be some level of interview process. So how do they operate with the team? Absolute must that you should have a fair market value assessment process. Onboarding process, this is where I see the biggest gap. We just assume that we have hired a medical director, everything's gonna be beautiful going forward. No, please make sure, let your medical director know that you're gonna work with them for the first 6 weeks of an onboarding process. And what is an onboarding process? It could be basically for them to know exactly what are the issues are, for you to guide them and coach them into what are the key clinical and regulatory demands you have. So really have a more conversation on the front end of this relationship. For example, for all the 4 organizations I work with, we have a toolkit. We give these medical directors a toolkit. We meet with them every month to go over how things are going. So there should be a reasonably good onboarding process. And then, please assign your medical directors at least 3 or 4 key things for the first quarter. I think that's one of the biggest things I see, that when the medical director comes in, they just start doing what they know what to do best, right? What is the one thing which doctors do? Is to provide care. They will just get very busy providing care, and then you have lost them because they're just like, oh, I'm just too busy. You need to set this expectation with them that they are there as a medical director to be your quality improvement champion, but you can do it very easily if you assign 2 or 3 things to your first quarter, right? And here are some good examples. Make sure your quality assurance meetings, there's a very good structure around them. Do not wait. So make sure that you have, like, hey, Dr. Smith, we're gonna have first Tuesday of every month. If that works for you, please let me know. And I know most of you do that, so that's easy. But please pull them into utilization of lab costs and polypharmacy review. That's a must. So these are some pointers I'm giving you, which physicians love doing if you just give them a structure. So please think about these few things I'm giving you. You don't have to worry about all those 4, 5, 6, 7 things, but for the next 3 months, please take those 2 or 3 things and work with them on these things. They love having those focused points to work with. Infection control and antibiotic stewardship is a big one because, of course, we are at the tail end of a pandemic. Make sure that your infection preventionist, how many of you are here an infection preventionist? Awesome. Like, there cannot be a better partner for you than a physician. You should have your own assigned time. Like, the administrator should have their assigned time with the medical director every week. The DON should have it. But man, the infection preventionists have to have an hour of time with the medical. I'm telling you, there's just absolutely must that you have to have that association where you need to sit down with them and show them exactly what are your infection rates, what is the use of the McGear's criteria, how long antibiotics are being used, and what are, so those 3 or 4 things are a must, and the vaccination rates, right? So please make sure that you utilize your medical director's time. It's just a must now. And then, chart review for hospital transfers and complex clinical matters. I'll talk more about that. I have a whole lot to say about this process. I just published this article in McKnight about this, I think it was 2 weeks ago. I'll send you guys the link on that, is how we are setting that weekly hospital transfer review process. Survey participation, make sure that your medical director knows what role they're gonna play. Do not put a rookie medical director in front of the surveyors, please. Please coach them in how can they be an effective partner for you to, for the surveyors. And then make sure that they, at least once a quarter, you do some level of clinical activity or some educational activity for the families in your buildings. There's really nothing better than to market your organization better than having a physician lead a family day. A lot of buildings do that. It's just one of the most fun things you could do. What a great use of time for your medical directors to be doing that in the evening. And then set up an education for the staff on a regular basis. So pick a couple of those things with your medical directors and then start working on those. And then within a year, you will see that you are actually engaging them more through these activities. So at Board Care Partners, that's my organization. As the Chief Medical Officer, I work, as I said, multiple organizations. So this is what we try to do. How do we set these structures up? We basically focus on what impact our medical directors are having by doing 4 things. Number 1, we set up an ongoing communication. So one thing which I do with these organizations is right away is set up a medical director council meeting. Every 2 months for these large organizations, we actually set up a structure of a 1.5 hour meeting. It's called the Medical Director Council. And we actually create a presentation where we give these physicians updates, we give them some best practices and how things are changing, we give them some regulatory updates, and then we share metrics with them on a regular basis. Like, hey, organization-wise, this is our infection rates, these are our polypharmacy rates, these are our COVID rates. So you could actually do a version of that. Every 2 months in your buildings, you could actually have a meeting which is very much medical director and data-driven, right? So must is for you to make sure that you're having weekly meetings. The administrator and the DON has to have this weekly meeting with the medical director. The other thing which we do is we work with the medical director to design medical services. Who is the nurse practitioner? How often they're coming in? What is the process for new admissions? What is the process for call? So that's number 2. Number 3, compliance is a must. We need to make sure that there's a good contract, that they submit their hours, which are non-clinical hours. They're not double dipping, as I mentioned, so we need to keep focus on that. And number 4, we talk about how can physician be a partner in day-to-day QAPI process. So these are the 4 angles we have. I just want to share those with you, that how we work with large organizations so that make sure that their medical directors are bringing value. So as I mentioned, what is communication like? Set a cadence. It's a must that as an administrator, as a DON, you should have the same meeting. Tuesday morning, coffee with the medical director, coffee with Dr. Smith. That should be your thing, right? Of course, they'll miss a few here and there. That's okay. But please set a friendly meeting with them where you share thoughts with them. Just a 15, 20 minutes check-in with them, right? So that's a must. And then when you do a QAPI meeting, please pull your medical directors in. That's the biggest opportunity I see. Do not just make sure that the medical director comes in a meeting and then sits through it. Help them 15 days, 2 weeks before the QAPI, you need to bring in the medical director and say, hey, Mr. Medical Director or Miss Medical Director, this is what the agenda I'm thinking about. What do you think? What else do you think we could talk about? And make sure there's always a medical director corner in that QAPI. Always pull your medical director in to say something about new medicines that are on the block, new diabetes medications, to talk about polypharmacy, to talk about infection control. There's 2 RSV vaccines that are being released now. Please pull them and ask them. They love doing that. How many of you actually put that pressure on or expectation of medical directors? Any of you do that? Like, do you expect your medical director to speak on the QAPI with their own agenda item? Right? Many of you don't. Please include that in your QAPI meeting as an ongoing agenda item, but show them the agenda 15 days. It's just respect to them, right? They love it. Like, man, thank you for pulling me in. Thank you for asking my opinion. And that also keeps you on your toes. When you have that 2-week deadline to set the QAPI agenda, you're coming up with a reasonably good agenda, right? You're not just putting it together a day before. It's just not a data dump. It is more meaningful. It is more fun. So think about that strategy. I have used that strategy every place I used to be medical director, every place. I took it personally. I used to feel insulted when I was not pulled in. I'm like, man, you're calling me one of your partners and you didn't even tell me that what you're going to speak about QAPI and you didn't even give me room to speak? Shame on you. Come on. I like, limelight. Give me some limelight for 10 minutes, right? So please pull in. Physicians love that. And then, of course, get their say on policies and procedures, show them the metrics, talk to them about strategy. They love that. And then make sure that they are customer service driven, right? I mean, sometimes physicians can use words and language, they don't mean it. You can always coach them around that. And then any quality improvement initiative that you are starting, make sure that you get their feedback. So that's the kind of communication you need to have your medical directors. Compliance is a must. I'm just telling you that OIG is very focused on that. Please make sure that your medical directors are getting paid for what they do as a medical director, not as a clinician. So otherwise, you are in a big kickback and stark violation. You should have a contract with role clarity. There should be fair market value based rates. They should give you a very clear and accurate log of hours. They are providing administrative service. They should steer clear from discussions on referring patients. And there could be other things you could be making sure that you are hitting. And one thing which I really like about my job, 9 years ago when I became Chief Medical Officer for Signature Healthcare, suddenly I had to manage 120 physicians in these roles. So I went back to my CEO based on my own vision. I said I need to create a technology for that. So I actually created an app for that. And this is the first ever and the only app that has been created to manage physicians and medical directors, and is now being used for other things, for teamwork and compliance across the industry. That's where we got the McKnight's Award. But it is such an important aspect. Compliance with your medical director is such an important aspect. Please take it seriously. You do not want to get in trouble. And this is just kind of the visual of the app, which basically they submit all their hours through it. You actually push education to them through it. You can give them all their metrics through it, and then they report all their hours to your AP or your compliance office directly so they can get paid. But the beauty of this system is that you can see what your medical director is saying, claiming that they're doing for you as an administrative leader. And you get to approve or disapprove that, right? So it actually brings a whole team together regarding what and you can actually set priorities for the medical director, what to do. Like, what are the 3 top areas? You can actually set those up. So the point is that you need to do anything you can do to formalize a quarterly expectation with your medical directors. Go quarter by quarter. Dr. Smith, let's sit down. Let's talk about, for the next quarter, I need your help with polypharmacy. Man, my nurses are tired of doling out pills. Can you please help me with that, right? So give them a very targeted task for the next quarter, no matter how you do it. It's an app or not an app, just make sure you do that strategic approach with them. You need to actually pull them in for medical services quality. Who are the practitioners that are coming into your buildings? What do they do? What practices do they have? Are they still prescribing cranberry? Are they still putting people on 11 years of antibiotics? Everybody's getting PPIs and H2 blockers? Are we still stuck in the 19th century? Your medical directors, if your medical director is stuck with them, you got a big problem. But your medical director needs to be evidence-based, and they need to make sure that nobody's using all those dumb things we used to do. It's we just never knew anything better. Like, everybody had to be on a multivitamin, a zinc, a potassium, a calcium, right? I mean, come on. We know none of those things work anymore. So please make sure that you pull your medical director in to help you. What kind of medical teams are entering your buildings? Call availability is their responsibility, telehealth protocols, special programs, all of that really, and then please pull your medical director in. If your building does not have a weekly process to review your hospital transfers, man, there's no way you can provide good quality. You will never satisfy your healthcare systems. So please make sure, one thing you should pull your medical director in is a weekly conversation around, let's look back 7 days, not 11 days, not 22 days, not 3 months. Forget about all of that. Last 7 days, what are the negative outcomes that happened in my building? Hey, Mr. Medical Director, or hey, Miss Medical Director, let's talk about that. They love case-based conversation. Give them the stage. But when you give them the stage not as a leader, but as a team member. Coach them in that. The CNA should have the same say. You should have the same say, and they should have the same say. They're just part of the team. Create a very interprofessional weekly process. I lead 7 or maybe 8 meetings every week. Every week, I'm doing them in person or remotely. Even though I think I have more than 300 nursing homes that I oversee in all these structures, I still personally am part of 8 meetings every week I do, because I thrive of it. I get so many ideas out of it. Every innovation I am able to create is because of that interprofessional engagement. It's the most fun thing to do when you have 2 to 3 cases to discuss with an interprofessional team, the new perspectives you get about those cases, the dumb and silly things that come to light, and then you laugh about them as a team. It just makes you a better team. So promise you that if anything I can give you is this, that engage with your medical director in building an interprofessional, once a week, 35 minutes meeting where you look back 7 days, discuss all your bad outcomes, which is usually 2 to 3 cases, and laugh about and talk about them and have fun about them. Because as you discuss those 2 or 3 cases, in a month, you pretty much know all sick people in your buildings together as a team, right? All the sick people now, everybody knows. You have cut down all their dumb medications. You have talked to their families together now. The work becomes so much fun. And the reason I'm engaged in these 8 meetings every week, because these buildings don't want to let me go off me. Like Dr. Nazir, we want to continue, So of course they bring their medical directors in too, they bring their nurse practitioners in. So just can't speak more about your medical director role is that you can do all of what I said in this one meeting, right? It is cadence, it is education, it is talking about regulations, it's talking about polypharmacy, right? So in one 35-minute meeting, you can accomplish a lot of that. And then your medical director can actually charge you for that time as a medical director, right? Perfect time for them to spend with you is 4 meetings a month where they're sitting down for 35 minutes with you. What a beautiful, beautiful medical director role to do. And then when they are part of COAPI, they need to be regular meetings between medical director and key departmental leaders, infection preventionists, social worker, nursing, depending upon what initiatives there are. They need to be pulled into those meetings. As I said, pull them into the COAPI agenda, give them space to speak, and then set up a monthly, quarterly COAPI structure. Every medical director should get some kind of a dashboard. So that's one thing which we do at Abode, is that we work with these organizations and we work with their IT teams, and we actually build a medical director dashboard. And again, it doesn't have to be very fancy. The more complicated you make, the more ignored it's going to get. It's just not about making it fancy. Give people 3 things, that's it. And those 3 things should be the ones which are the 3 things big on your mind. And I can promise you, I can guess all of those right away. I am pretty sure, I promise you, that hospital transfer is the number 1 thing on your mind. Number 2, lab costs are killing you, right? They should be on there. And your nurses are sick and tired of giving all those medications, right? Number 3. So I promise you that I've already guessed the 3 top things which are keeping you up at night, which your physicians can help you. Pull that in the dashboard. So those are the 3 things which we put on the dashboard. We also put some infection rates on there. We also put vaccination rates on there. And we also put digital compliance on there. And what is digital compliance? Because of EMR, now medical directors have to make sure that all orders are being signed. I know many of your buildings have like 18,000 orders that have been signed. I know that you have, many of you have those buildings, right? 7,000 orders not signed. So give those 5 or 6 things to your medical directors to look at and keep them very true to helping you with that. I call these 3 C's, communication, collaboration, and care. Your medical director should be about those 3 things, and I'm going to give you an example for that. And I'm going to leave you with that very real example. And this example is based on real stories, okay? So this is not something I kind of created on my head. These are real cases. So Squeaky Meadows, of course, a fictional name, 130-bed SNF with more than 20 short-stay patients. On a Friday, a new patient admitted with aspirin, Eliquis, which is an anticoagulant, and clopidogrel, which is, again, antiplatelet agent. This patient is on 3 medicines which are causing them to bleed, right? Some patients do need these, right? Relatively new nurse manager is concerned, very rightly, because this patient is taking 3 very dangerous medicines for bleeding, and they're anemic. Their hemoglobin is 8.9, and they're concerned. The director of nursing, though, says, please don't call the medical director, because he's also the attending physician. This is late on Friday, and to leave the recommendation in the folder. 2 weeks later, patient gets transferred with the coffee ground stools and emesis, and then dyspnea, and hemoglobin of 5.2. We see these cases all the time, right? Among other things, if you do a root cause of this, the next day if you do a hospital transfer review in an honest way, you see clearly there was poor communication, there was lack of collaboration and trust, and their care was just, and because of that, the care was not delivered. I see this all the time. All right, so we do other examples. When we looked into this building, there were clear other examples about the medical director who mostly relied on his or her nurse practitioner, who did the most of the work remotely as he was too busy to come to the building. How does this impact teamwork? When the CNAs say that, you know what, I have to be here every day, why does my physician does not get to come here? Like, why do I have to hold this camera? When I'm so busy taking care of my task, now I have to do double work because I have to hold this camera for 2 hours for my medical director? That's not fair. To me, that's the biggest problem that has occurred out of telehealth. I'm not a big proponent of day-to-day telehealth. I'm a big proponent of using it remote and very special cases, but man, like every single time I have pushed down on it, like, no, we're not gonna do it. Because, come on, it's a big problem of teamwork. The agency staff call the physician without formal assessments. That's the other problem we have, that there's agency staff, they're just calling the doctors, there's no SBAR being done, and then many patients are being unnecessarily hospitalized. Due to high hospitalization rates, the medical director devises on their own. They're like, oh, I'm going to do my own copy. And I'm going to come up with this idea that all these patients that come into my building are going to get labs every week. That's my answer to this problem. And this is a real intervention our physicians are using these days, right? Let me just do labs every day and I'll be in the better know because hospitals do labs every day. The medical director on a copy actually said this, that the consultant pharmacy recommendations are silly and declines to accept any after skimming through them. Happens all the time. So these are some other examples that were rampant in this building. Now, if you really look at the reality of the silly recommendations and what was really going on, the facility NP, the nurse practitioner was quite engaged, and she was actually visiting twice a week, but sometime over the weekend she was coming in. The NP, but here's the reality, the NP and the consultant pharmacist never met in person, never, because the consultant pharmacist came once a month at a different schedule. The perception was that was created that practitioner and the medical director are unimpressed by cookie cutter and silly pharmacy recommendations. The reality was the consultant pharmacist is very engaged, who invest a lot of time, even though they come just once a month, but they're very engaged. But because there's no structured communication with the doctor and the NP, they just give out these very general recommendations, right? So because of the broken system, everybody's coming across below average. Nobody's trusting anybody. And this is the commonest scenario I see in the buildings at this point between the clinical teams, the nursing teams, the physician NP teams, and the pharmacy teams. A huge problem I see in this 21st century. When we are talking about robots and we're talking about AI and chat GPT, we can't figure out basic communication. So, of course, there's all-round lack of communication. There's perception that the NP and the medical director do not prioritize important issues and don't really care. That's what the CNAs are saying about the medical director. The director of nursing perceived significant burden from all of it, and she perceives that the system doesn't care for me and my home, and I'm alone in this fight. And the collaboration, multiple missed opportunities for simplifying, improving care, and promoting teamwork are obviously seen in this case. So the consultant pharmacist efforts are not. So what are the price we are paying? The consultant pharmacist efforts are not resulting in any impact. You have a very expensive resource, right? These consultant pharmacists are expensive. But what the work they're doing is not helping you as a director of nursing or as an administrator. It's not helping your residents because all the recommendations are being declined by the physician. Like silly, 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 silly. Director of nursing is burning out. The nursing burning out due to polypharmacy. They have to count pills every shift. They have to give pills all the shift. They have state regulation issues because of that. They have IJs because of it. Cost of medicines is a big issue. Multiple medication adverse effects resulting in medication cascades, Lasix, potassium, right? And then a lot of people, what is the top 3 causes of hospitalization? It's inappropriate medications, right? Inappropriate medication continues to be, for decades, the top cause of ED visits. And then many, many other things I'm sure you can come up, which are happening because of these issues. So how can we use the 3C framework to flip this around? Let's talk about the care collaboration framework. Let me give you some tips and ideas, and this is what I do every day. Like, these are, honestly, anything I do is not rocket science. In my consulting work with these 4 organizations, all I'm telling them is very basic, simple things which they already know, but they're just not ignoring them, right? So let me just give you some ideas here. The director of nursing in this building hears about AMDA, Society of Post-Acute Long-Term Care Medicine's Drive to Deprescribe campaign. So if you have not heard of it, please look it up. You just go to paltc.org, post-acute long-term care, paltc.org, which is AMDA's website, and then you can see Drive for Deprescribe. So we have more than 1,200 nursing homes which are signed up for that. So at least it's free, just become part of that. And then she reviews the materials which are available on the website on implementing medication optimization and deprescribing at a SNF. She meets with the medical director and consultant pharmacist to set a culture of 3C. You will have to have that conversation. It's not going to happen magically. You will have to sit down. You will have to talk. And what a clear low-hanging fruit to talk about, right? There's nothing easier to talk about with anybody than the epidemic of medication in our country. Nobody will disagree. I promise you. There's no physician will laugh at you. They're like, everybody like, yeah, you're right. Yeah, you're right. So easiest thing to agree on with anybody is the pandemic of polypharmacy we have in our country. Great conversation opener for you. If you do not have a good relationship with your physician, or you never took time, or they never took time, this is a great piece of initiative to kind of start on. Implementing medication optimization and deprescribing. This is a great initiative to do all I said about medical director structure. So use this polypharmacy initiative to actually build that teamwork which I was talking about. So I'm giving you a very, very easy way of getting your foot into a new era of medical director relationship. So the director of nursing and medical director in the Squeaky Meadows buildings, they review the D2D letters, which are available on the website, which are for the family and other physicians. You can just print them off, put your name on there, so that every facility physician and NP and the family gets that. Like, hey, family member, we actually are a polypharmacy building. We manage medications proactively. We are part of this campaign to get your loved one off harmful medications, right? So you can use that. Consultant pharmacist, practitioner, and medical director, and director of nursing meet and exchange contact information. Easiest thing to build trust is give your cell phone to people. I give my cell phone to every single patient I see. Every single nurse I talk to, every single email I send has my personal cell phone on it, and I promise you, nobody calls me unnecessarily. But it builds a beautiful relationship when you give people personal information. All these partners deserve to have it couldn't be your cell phone, it doesn't have to be your cell phone, it could be your email, but the point is, give them unlimited access to these people if you want to build trust with them. And so we promote that at Abode. We actually create calls where we invite nurse practitioners, the doctors, and the consultant pharmacists, and we say, all right, let's talk together. Like, let's get to know each other. Hey, Julie, you work with Dr. Smith, say hi to them. Hi, Julie, hi, Dr. Smith, how are you? This is my email, call me anytime. Hey, when are you in the building? Monday morning? Oh, okay, next time Monday morning, I'll make sure I'll see you. Just create opportunities for people to talk. They become good friends, and they work together better. It's very easy for me to call somebody silly when I know them personally. It's very easy for me to call a consultant pharmacist silly when I've never met them, right? So perceptions change when we know people. Simple thing, get people to know each other. All decide on a monthly huddle to review polypharmacy-related issues and to address consultant pharmacy recommendations together. What a beautiful spend of medical director 12 hours. 1 hour of that 12 hours your medical director is charging you time for goes towards this huddle, where you sit down and look at all 13 or 22 consultant pharmacy recommendations together. Now you're getting to know these cases together, you're talking about them, you're learning about them together, you're learning some best practices around medications. Everybody is learning, everybody's building that teamwork. So use that 1 hour you are giving your medical director for those services. Do have a huddle where your consultant pharmacist can call in. If they can't be in there, that's fine, they can call in, right? The medical director can call in too for that 1 hour, no problem. The Teams or Zooms are pretty good these days, right? So now, what happens at Squeaky Meadows? Because of this 3C culture, some new roles have been added. Director of Nursing joined AMDA due to do webinars. All 3 members actually now are attending these quarterly webinars that AMDA does on Drive to Deprescribe. They educate all staff about medication optimization thanks to those newsletters. They just print those off. Add new polypharmacy-related metrics to the monthly COAPI meeting. So the DON now adds a section to the COAPI. Average pills taken by long-stay residents in my building for scheduled medications. Just become used to that metric. This is one of the most beautiful metrics that can improve quality of care. It took me a while to figure it out over the years because we used to count all different kind of pills. We figured out if you look at average number of medications your long-stay residents take on a scheduled basis, just follow that trend. That will help you immensely. So the DON adds that to her COAPI meeting as a metric, and then they educate all staff because this case was about aspirin, right, and anticoagulation. So they took the opportunity to educate all staff that, hey, aspirin is not as simple as you think. It actually causes bleeding in our older population. So that's what the DON did. What did the consultant pharmacist do? Same thing. Joining the AMDA to D2D webinar, sharing cell phone number with the NP and the medical director, provide data. They say, you know what, I am the consultant pharmacist, I take that on. I will give you the data every month. Please hold your consultant pharmacist just to that simple one thing. Hey, Julie, please can you give me data trending on my building, how many average pills we are giving out to our long-stay residents? And then provide list of all residents on aspirin and anticoagulants. So the next 3 months, remember the 3-month initiative? Now Squeaky Meadows promises to themselves, like nobody in our building would be on aspirin and anticoagulation until we have done a deep dive and justified it. We will go through all 11 cases of people who are taking an aspirin and anticoagulant, and we will resolve those matters after having a conversation, right? So that's an example how you take a little issue, focus on it, fix it, and then you move on, right? So an example there for you. And then what did the medical director and the NP start doing? Again, joining the AMDA D2D webinars, review weekly polypharmacy data from the consultant pharmacist, and act to deprescribe and optimize. It's not about taking pills away. It's also about adding pills. Like how many of our people with fractures are never taking bisphosphonates, right? That's crazy. Like they come in with a hip fracture and they're not taking Fosamax or vitamin D. Why? They should be on it, right? How many times we have patients with diabetes and they're not taking lisinopril or an aspirin or a cholesterol medicine, right? These are the things which cause them to go to the hospital, right? So medication optimization is not about deprescribing only, it's also about adding medications, right? So this is what the medical director and the NP committed to as part of this quality improvements 3C culture. They review all consultant pharmacist recommendations via phone call every month as a huddle. And then finally, they are sitting there in that meeting, discontinuing aspirin and anticoagulants on these people who don't need them, right? So you can see how a culture where there was lack of communication easily around a very simple initiative of polypharmacy deprescribing and optimization turns into an opportunity for people to become a great team together. I talk about some of these approaches in this article. You can Google it, Bake in Success with Advanced Clinicians in Place. That was just published in McKnight, so you can get some of the ideas there, so I just leave that with you. All right, so as I promised, we have wrapped up in 45 minutes because I know people can't listen beyond that. We will have some time for questions and answers for sure, but just leaving you with this summary, that physician partnerships are critical to improving outcomes in post-acute and long-term care settings. We need to establish formal structures of medical director roles to assure engagement and bringing value. It will not happen automatically, I promise you that. Focus on communication, collaboration, and care culture can improve medical director partnerships. Health systems should establish, you are all health system. You're not a freaking nursing home only. You are a healthcare system now. Everybody thinks that of you. Like all hospital systems think that of you, right? You are a healthcare system, a force to be reckoned with. Think of you that way, right? You're not just a nursing home, you're a healthcare system. You're really taking care of sick people, right? So you need to establish clear medical director priorities, implement data-driven strategies to implement and to gauge success. So with that, we are done. I would love to engage in a few minutes conversation, otherwise we can get 15 minutes back. So I don't know if there's any questions.
Testing.
If anyone has any questions, I'd love to bring the mic to you.
People want their 15-minute back, I guess.
I do have a question. If you do have an MD who isn't engaged, just comes in and out, kind of does their own thing, you can't always reach them, how do you get them more engaged with QI and actually taking an active part in the facility, not just being the one who comes in and out?
Yeah, so actually I had 2 meetings this week in Indiana where the buildings reached out to me. They just, so I kicked off with American Senior Communities 3 months ago, so I did this opening presentation when I started with them as a chief medical officer, and actually gave them some of these best practices, and people got inspired by it. So I had like 4 or 5 buildings email me like, we want to fire out our medical director. He's not doing any of those things. I'm like, hold on, time out. So it shouldn't be very reactionary. I mean, because again, 10 years ago, had you asked me this question, I was like, fire them, like find somebody new. But I know better now. I think the biggest reason they are not engaged is because you have not set the structures up. So I would recommend you need to sit down, take out the contract you have. Your contract is pretty powerful. This is really an important thing. And look at the contracts exhibit, and most of your contracts exhibit will have a lot of things your medical director should be doing, which you want them to be doing, and they're not doing, right? So say, hey, Dr. Smith, I'm new here. I'm sorry I've not communicated with you. I would just like to work on quality improvement and really need your partnership. Would love for us to meet regularly. Can you meet with me this week? Give me a time. So you set that time up. Then you have the contract there, and then you have some metrics there. Say, hey, Dr. Smith, I really would love your partnership to improve quality, and based on our partnership through this contract, I would really like you to help me meet with me every week so we can discuss quality around hospital transfers, heart failure care. Can you please help me with that? So you don't have to say that, hey, medical director, I really want you to be more engaged. Can you give me more time? Or instead of making it a general conversation, which sounds like a little bit more of complaint, announce it in a positive way at start of a new era where you're going to work towards quality improvement with them as an amazing partner. So I promise you, most of the physicians will respond very well to that. Make it meaningful, make it actionable, make it clear, and then commit to meeting with them on a weekly basis. To me, that's probably the best approach you can take. All right, if you guys are shy, take me on for the LinkedIn approach. That's my email also. So I promise to answer any question you have subsequently. So, is there any other?
Yes.
Yeah.
Yes, I do have one more question. So a lot of times facilities have issues when they're changing over, let's say nurse practitioners coming in to work on with a physician, then you have multiple areas of expertise. You're getting too many medications written, you're getting too many labs ordered, which in turn takes up your staff resources as they're doing the process. So what would be the best approach for us as to approach the medical director to help us with this?
Yeah, no, that's a great question. I think that's just the commonest issue one of the common issues I deal with in these conversations is it's a zoo. so many buildings, just a zoo of people coming and coming out. Too many. More physicians is not better care, I can promise you, or more clinicians is not a better system. I think very limited data we have just very limited data. We don't have a lot of research in this area, but it points towards the fact that you need stability of 1 or 2 physicians or a practitioner, that's it. So you have to create that 5-day-a-week nurse practitioner model. To me, I think it's just, if you're not there, you're just missing out. So you do not need 3 or 4 NPs coming in. You may have a couple physicians coming in, that's great, but try to work with both the physicians to work with one NP. I call them the quarterback NP. You have to have one quarterback NP, and that quarterback NP should be sitting down with you for 30 minutes every day in your quality meetings and should be prescribing and de-prescribing as you're talking about things, right? You shouldn't have to take time to take notes on a napkin, call the doctors, beg them, and some of them will listen all that. No. You want to set up a system with help with your medical director that this quarterback NP is going to be my extension. You have to have an NP as an extension of you, as part of your team, paying attention every day. So if you have 3 or 4 NPs coming in, I feel sorry for you. I think you need to take control, work with your medical director to come up with a system where you have one practitioner and minimize really that traffic flow. Now, of course, you need a consultant. That's awesome. You should have a pulmonary consultant coming in. But by regulation, please do not pay any of these consultants any other dollars, because that's a huge issue of concern for IG, where the medical director is getting paid, pulmonologist is getting paid, psychiatrist is getting paid. That era is over. You're going to be in huge trouble. Only person who can get paid is the medical director. There should only be one medical director. There should not be no co-medical directorships. These are very risky areas, so please keep away from those. I'm done.
Thank
All
you.
right. Thank you so much for your time. Appreciate it.